afternoon, ladies and gentlemen. Welcome to the We are sorry for the late start of the program. Without much to say, I'll invite the registrar, Ms. Ya Amankoponi, to do the introduction of the chairperson for the education. Can we please put our hands together for her?
Thank you very much. So for UHAS, we want to be on time, and so we're going to begin, even though we are still expecting others to join. We note that there are many online joining the program, and so for those in here and those online, you're welcome to this afternoon's event. Our chairperson, actually, for the UHAS community, she needs no introduction. I was with her last week in Accra, and the number of people who came by and said, "I saw you on TV, congratulations, madam, I saw you on TV." I said, "Why?" And I chopped some, because I was working with her, so all that, "I saw you on TV, hello, madam, congratulations." I said, "Yes, I'm so happy." We call her Prof. 1, Professor 1, the first full professor in nursing in Ghana, West Africa. Abba, this is the person who is now the Vice Chancellor of the University of Health and Allied Sciences. Before she became Vice Chancellor, she was the Dean of the School of Nursing and Midwifery in the University of Ghana, where she left a legacy that is unmatched, and she has come to begin same here. Ladies and gentlemen, here and those online, our Vice Chancellor is Professor Lydia Aziato, the chairperson of this afternoon's program. Shall we give her another applause? Thank you, Miss.
Thank you very much. Your phone, I think. Pro Vice Chancellor, Registrar, our August distinguished speaker for the day, deans, directors, HOD, convocation, students, guests, online participants. We are very, very happy to host our collaborator partner from Amsterdam. I think a few months ago, we had a Zoom meeting, and we said the relationship must begin from somewhere. So he said, "Oh, he's coming to Ghana." I said, "All right. So visit us when you come." And he offered to give us a lecture when he comes to Ghana. He's here with colleagues from Farm Access. You're welcome to the university, and thank you for bringing him, giving him the security and all the comforts to bring him here and take him back. So we are looking forward to a lasting relationship with you, Prof. Tobias. And he happens to be one of the supervisors of our Dean of International Programs, Dr. Alasan. And so we are very, very proud that you are continuing to work with us. The topic as we have it, from COVID to digital epidemic preparedness in Africa, is very, very timely. We had some meeting before this event. Do we have to wait for COVID before we now expand issues of digitalization in healthcare? We digitalized teaching and learning during the COVID time. but how we digitalize our service, our care. UHAS happens to be a health university, so service is part of our vision. And I am very, very glad that Prof is going to talk to us in this space. I must say that UHAS made history becoming a COVID testing center for the Volta region. And I think that is something that we are very, very proud of. And I also want to acknowledge Farm Access for the contribution for the establishment of the COVID center during the period of the pandemic. Again, I want to say that anytime you come to Ghana, don't forget to add UHAS to your agenda. We'll be very, very willing to always make space for you and listen to you. So on this note, I want to say that I'm humbled to chair this program, and I hope that we'll be here as soon as possible. Thank you very much, all of you, for coming.
Thank you very much, Prof, for agreeing to chair the program. We invite the Acting Dean of the Office of International Programs, Dr. Robert Kaba, to do an introduction of the visiting lecturer.
Good afternoon, Prof Chair, Prof Vice Chancellor, Registrar, Deans, Directors, Faculty, Students, our distinguished speaker, the guests from Farm Access, you are all welcome. I think my job this afternoon is pretty easy and at the same time difficult in the sense that Tobias is somebody who really is part of my life history. So by way of introduction, who is our guest speaker for today? He is currently the Director of Research, Farm Access Group at the Amsterdam Institute for Global Health and Development in the Netherlands. He is a molecular biologist by training and then a public health specialist. By way of his academics, he holds an academic chair at the University of Amsterdam, oftentimes leading research in Africa. So the chair was just making a case that he should have UHAS in mind. So we want that one of these days we should be able to convince him to take up a chair here to promote research for us. Within the global space, he's a chair of the WHO Global HIV Drug Resistance Advocacy Group. I can imagine that's a very big post. By way of research interest, he's into diagnostics of infectious diseases in Africa. He is also into healthcare quality and improvement, and then also innovation in health, financing, and then mobile health technologies. Most importantly, he is a mentor in the sense that he leads in the training of PhDs and master's students. And I'm really proud and privileged to mention I am a proud product of Tobias. By way of his scientific records, it's not in doubt. Tobias has to his credit over 200 scientific publications and still counting. And if you look at his H-index, 49. And as academics, we know what this means. So I wouldn't want to belabor the point. I want to say you are welcome, Prof, as you take us through from COVID to digital epidemic preparedness in Africa. Thank you very much.
Good afternoon. It's a real pleasure to be here. I feel like a pop star. That is okay. Some technical instructions. So I feel like a pop star in a concert, not completely sold out, But I hear that there is a lot of people also on the Zoom, so that's appreciated. And greetings to them as well, wherever you are. It's a pleasure to be here. I would like to thank Professor Lydia for her time, hospitality, and the unique moment of meeting earlier today. And indeed, yeah, Dr. Robert, sorry. Yeah, I mean, it's such a pleasure to see you here, and I think you have been a tremendous advocate for the work we are doing, and your dedication to quality healthcare is phenomenal. I am proud to have delivered you as my scientific son, together with maybe a scientific mother as well. No, but thank you very much for your hard work you did in the past and for the work you're going to do in the future. And definitely we keep in touch. And more than that. So, my two bodyguards here are also from PharmAccess. Dr. Kwasi, Dr. Maxwell. I'm working with PharmAccess, which is an NGO. I will tell you a little bit about it so that you have an idea who we are and what we do. And then I'm going to take you through a whole, let's say, history and of events around COVID that happened, and in which digital healthcare, like we just discussed, played an important role. And I think that is the future for health and healthcare in general. Digital will grow and grow. Artificial intelligence, telemedicine, you name it and it will be there. At the moment, for example, I'm working on an app on a mobile phone that when you cough in your phone, you can use artificial intelligence to know whether you have an upper or a lower respiratory tract infection. And just imagine the artificial intelligence behind this, the enormous amount of technical work that is needed, but eventually the very simple application that if such an app exists, how many people can it help? Being at home, somewhere in the middle of nowhere, and being worried about your child coughing. And of course the phone will not tell you you have this or that disease, but it will tell you you better go to a doctor or you can be okay at home. And that is an important message already. So in that respect I'm going to tell you a bit more. But my two bodyguards and my big friends, Maxwell is the director of PharmAccess in Ghana. I think we exemplary workshop yesterday in Accra, a nice symposium on all the research that was done and is done around PharmAccess activities in collaboration with the stakeholders in Ghana. And we discussed a lot about how does research help policy and health implementers to get things done better. So I'm proud, and thank you very much for that workshop as well. And Dr. Kwasi, my brother from Amsterdam, and the director advocacy of PharmAccess. He has a heart for Africa that is even bigger than mine, I'm sure. So thank you for facilitating and introducing me to the various important people here, and it was a pleasure. What I'm going to do is tell just a little bit about PharmAccess, and I've just taken PharmAccess is an NGO. Don't get a company. We are not selling drugs, or we are basically we started in 2001 because we believed that AIDS treatment in Africa should be done now. AIDS treatment was already there in 1996. And even in 2001, 5 years later, it was not available for Africa. It was a crying shame because the far majority of AIDS patients are here in this continent. That's how PharmAccess, access to pharma, that's how we started. Just to explain to you, and this organization was founded by late Professor Joep Lange, who was a real worldwide advocate for AIDS treatment in resource-poor settings. So what do we do now with Farm Access? Basically, I would say 5 big things. We try to look at health and healthcare in a holistic way. Healthcare is not only about a patient and a doctor, but it's also about a payer. Somebody has to pay. It's about policy. Yeah, there is a certain policy, health policy in the country, which can be different per country and per region. So it's the combination of patients, providers, payers, and policymakers that in a certain infrastructure that make a healthcare system. And there's public sector and there's private sector. And both of them play important roles. Almost half of healthcare services in most countries in Africa is delivered by private sector. So we should not throw away that possibility, but collaborate in a clever way. So public-private partnershiping has always been an important element for us. So one of the things that we're doing, this is about payment of healthcare, is try to assist and give healthcare insurance efforts in different African countries to reach out to as many people as possible, but preferably also the poor. Okay, so Farm Access is doing a lot of technical assistance to also in Ghana a lot to the NHIA, NHIS. So that is an area. Somebody has to pay for healthcare, and eventually the best way of paying for healthcare is by pooling risks in an insurance setting. We're doing it all over the world, so why not in the African setting? The second area that we are very much involved in is, as I said, quality. Quality of healthcare, because quality is key. I don't have to ask Robert, because he's a quality specialist. He did his PhD in that area. It's close to our heart, and it will always be close to our heart. So whatever can be done to increase quality and increase performance, we always try to support and provide innovative approaches. The third thing we're doing is maybe something that's less common and not easy to explain, but we call it care bundles. And this is basically the connection between patient and doctors in a digital way. So we take care that doctors provide the services that the patients are needing, and we also arrange that the patients know which services they are allowed to get under a given health insurance or other setting. And we support that digitally. In other words, it's a digital way to improve the relationship patient-doctor to really make it a bidirectional process and increase, again, quality. The other one, of course, is money. I mean, clinics and entrepreneurial people in healthcare need money to invest. So with investments, with loans that are achievable and that are payable and affordable through the so-called medical credit fund. So we are in that arena as well. And the last one, and that's basically my department, we do research on these interventions. And it's not us doing the research, but it is us trying partners, to evaluate the interventions that we're doing independently. Because that is a big belief by us. You should never judge your own work. Somebody else should judge your work and independently do research on it. And that makes that makes your message the strongest possible. So this is a little bit about Farm Access. We are in 4 countries in Africa, in Ghana, Nigeria, Kenya, Tanzania. Probably moving to a 5th country soon, could be Uganda. We have almost 200 staff. The majority of them are African colleagues, 64% I think is the latest. And we have 8 different offices in those 4 countries, including them. So that's the Netherlands at the 5th country. The list here is what I described to you. Okay, this is the whole thing, the mobile phone, like I said to you before. The mobile phone, digital health, is changing the world, and also here in Africa. We are here with the reality that no matter how many students you're going to train in this university, there will always be a shortage of staff in the healthcare arena, and this will grow. So digital and mobile phone health can at least help building capacity. That could be in the area of telemedicine, it could be in the area of chatbots and feedbacks, it could be in the area of digital diagnostics. And so there's a lot of complementary possibilities. And I think for a university like this one, like we discussed also a bit already with your Vice Chancellor, if you would build capacity in that arena, that has the future. So this is just an example of one of the initiatives of Pharmaxis is around NCD care and mobile. But basically, the topic I would like to concentrate on today is COVID. But the role of digital healthcare in COVID and how things can go from one step to the other, and how you can start in a small private setting and then grow to a big public kind of exercise. And how do you do that in a way that everybody benefits? So, this is the story of Kisumu, Kenya. It's East Africa. It's a different place than here. Far less jolly. I can say that it's always good to be here because people are friendly, have jokes, are teasing each other a bit. Kenya is a bit more serious. And this is the story I'm going to tell you about the COVID epidemic. So basically, what happened when COVID broke out, December 2019, then everybody was concerned about Europe, in my place, and what's going to happen. And then after a couple of weeks, we thought, what will be the consequence for Africa? This could be a nightmare scenario, or it could be something that is quite survivable. What will it be? And we were all very much, as Pharmaxis, active, and we thought we have to do something. We have to do different types of interventions. And we jumped into the water and just started doing all kinds of things, also in Ghana. And what we did in Kenya basically is we said, well, let's set up a monitoring system for COVID. And we started doing that in March 2020, before the first wave of COVID. Here you can see the 5 different waves of COVID in Kenya in the last 2 years. So we started doing this even before there was a single COVID case. And in a way, we were even panicking because there was no COVID, and we thought maybe there is no COVID at all in Africa. Good, but a bit awkward for us. Anyway, it didn't happen like that. There was a first wave, and then the second wave came, and so on. So this tells you something about epidemic preparedness, coincidence being really in time. So what did we do? What do you do when you want to go digital? What is the advantage of going to digital is transparency, obviously, but it's also speed. So what we did is we translated the paper forms on the left, the clinical case identification forms for COVID, into a digital small app, and we started collecting information on COVID from, in this case, 9 healthcare facilities in Kisumu. Kisumu is close to the Victoria Lake in Kenya, and we started collecting patient information. We supported those facilities to do so, and we started making a small dashboard using Google Maps to show where are the clinics and where are the infections. Because we thought at the moment there's an epidemic outbreak, then a policymaker wants to know, and a health implementer and a health manager wants to know, where is the virus? In which part of my county? What is the hotspot? Who are infected? Are it men, or women, or younger people, older people? Are they travelers or not? Are they nurses or not? So that's what we started doing. Simple digitalization of an existing paper system. Doing so, things became, of course, much faster. And also, this digital picture of Google was on the mobile phones of each and every policymaker in that area. In other words, the governor of this area could see on a day-to-day basis what was going on in this area. The health managers, the district health officers, they all could see what was happening. And that created, of course, a lot of momentum. So that's how we started. And then after a year, we thought, okay, this was a nice project. The whole thing is up and running. Time to step backwards. The place is in full speed. And then there was suddenly the outbreak of Delta. Maybe you remember COVID Delta variants coming from India. On the television you might have seen also all the horrible pictures of people on the streets dying. It was huge panic. I don't know how much panic there was here in Ghana, but in Kenya I can tell you there was real panic when suddenly COVID Delta was found out. Where? In Kisumu. By sheer coincidence. We just wanted to get out, then Delta came in. And Delta came in because the sugar factory in Kisumu had Indian staff. And they came back from traveling to India, to Kenya, and they brought in the virus. So there was panic. And then the regional health authorities came over to us and they said, you have supported 9 private facilities so well at making those Google Maps. Can you please help us to make this also available for the public sector? And that's what we started doing, of course. This is a paper about it. And this is the tests that we were using, rapid tests. And here you see a dashboard that we made, more sophisticated. And not 9, but now there are 33 facilities connected in Kisumu County, public and private facilities. And we made a dashboard where you could see the numbers of tests done, 10 times more than before. The weekly testing rates and positivity rates. Positive is red and negative is blue. So we could really see the Omicron outbreak as a peak. We could see who was vaccinated or not. Vaccination data. The positivity rate and the cumulative positivity. And we had detailed information on the Google map. Where are the infections? So this really went quickly and well. And then, of course, the neighbors, the other counties which are around Kisumu, which is another 13 counties in West Kenya, they came to us and they said, we want this as well. Please, COVID is everywhere. Can we please expand also to our counties? So that's when we got involved in 14 counties in West Kenya, covering almost 15 million people. Here you see the dashboard for those 14 counties. Now it's 111 testing facilities. And so you can see how a small private initiative, which is digitalized, can very rapidly scale up to a bigger public collaboration, a public-private partnership that covers 1/3 of the Kenyan population, 15 million people. And doing this type of work, and here you can see a shot of the outbreak of Omicron. You can see day by day how the virus is spreading. Red is positive again, blue is negative. So we really could follow the outbreak, in this case of Omicron. And with this information, policymakers could make good decisions. So what type of decisions, for example? Number 1, we found the first Omicron patient in Kisumu. And you might remember that when Omicron broke out in South Africa, and when it was reported to the WHO, then people closed the airlines to South Africa. And that was a disaster for that country, because it was holiday season, December, they expected tourism, and the whole tourism industry was suffering big time. The whole country was suffering big time. Well, you can imagine that Kenya also wanted to know, where is our Omicron, and can we contain it, so that our airlines keep on flying, because tourism is a very important source of income. So therefore, the Ministry of Health was extremely interested to get, as quickly as possible, Omicron data. And that's what we did. and we help them to contain that in certain areas and track and trace it. The other thing that we saw is healthcare workers, particularly nurses, they suffered a lot from new breakthrough infections. After they had been vaccinated, we saw still a lot of them reporting with new COVID infections, with Omicron. And that made us think, hey, we should maybe do something about that. We see in this disproportional level, let's accelerate booster. So our advice was to vaccinate each and every healthcare worker again with a booster, because they are at the front line. They have higher risk, and their vaccinations in the past were a longer time ago. And then your immune response is waning, so you need a boost. This was purely based on this geographic data that we collected, that this booster vaccination campaign took place. And the nurses got better protected. And the doctors as well, by the way. I'm not going to go through all the details, but maybe one more on the bottom. What we found is HIV positive people have a 2 to 3 times higher risk of getting infected with COVID, of having COVID symptoms, and of being hospitalized with COVID. So the policy advice that came out of here was maybe we could incorporate COVID vaccines in the standard antiretroviral package of HIV patients. So that's also what happened. And so COVID vaccination was not done nationwide, but it is concentrating on certain risk groups. And one of the risk groups became HIV positive people in Western Kenya. So you can see how data that you collect in a digital way, in real time, can inform policymakers and health managers to make sensible decisions based on information. Well, after COVID, of course, went down after the 5th wave, we all thought there are more diseases than COVID. Should we stop or should we continue with this successful program? And again, in collaboration with the 14 regions, we decided to continue and move towards 20 different diseases, not only COVID, including monkeypox, which at that moment was a real fear. People had no idea what was going on. So that's what we started doing. Same story. We digitalized the paper form that was usually used for WHO, and we made dashboards. And here you can see a nice dashboard of Western Kenya with the whole list of diseases, outbreaks, which is where and when. You can select on epidemic week, and so it gave complete transparency in what is going on where. And one of the things very clearly, one of the very clear conclusions, that if you look at weekly diagnosed infectious diseases, then in red you see the ones that are confirmed by a diagnostic, and in blue the ones that are only clinically determined. And you see there's a big gap between those two. Yeah, thank you. Let's see, maybe this one, yeah, this is far better. Thank you. So for us it was also very clear. The far majority of infectious diseases in this area in Africa is diagnosed only clinically and is not confirmed by rapid or any other diagnostic laboratory test. It shows you the big need for proper diagnostics for diseases in Africa. It's not new, we know it, but here we can quantify it. And based on that, we wrote a European Union proposal, talking about proposal writing. It was a big one, a 9 million euro proposal. It's called DIDA, Digital Innovations and Diagnostics for Infectious Diseases in Africa, to develop diagnostic tests that can fill that gap that we just saw. And so you see that from a small effort in 9 private facilities, you move from one to the other, to the other, to the other, and that's how you grow a network and a system. Diagnostics are essential. Maybe diagnostics are not that big part of the healthcare bill, but they do influence almost 70% of all your medical decisions. In other words, diagnostics, I'm a diagnostic guy, so I'm going to promote it a bit, are far more important than we sometimes think. So what is also important about diagnostics is that diagnostics, we think, should go to the people. The people should not go to the diagnostics, but the diagnostics should go to the people. It is striking, if you look at different examples, that a lot of people in Africa will never even get back their own laboratory results because of mistakes that are made by coding or by barcodes or by labeling errors or by logistical problems. And so you can, as a diagnostics person, concentrate on sensitivity and specificity and make it as high as possible. But when your connectivity is low, then the test will not even reach the patient. If half of the test get lost before the patient even hears about the result, your sensitivity and specificity is 50% by definition. And this is happening a lot. So this is also where the whole digital thinking of diagnostics comes from. The diagnostics should be close to the people, and we should use digital means to get those laboratory results at home. So the hospital at home instead of the hospital in the hospital. Of course, a lot of things cannot be done at home. Don't get me wrong. But of course, there's also stuff that can be done at home and that patients don't have to travel for and don't have to go into expensive days of waiting for a doctor in the clinic. So that's how this whole thinking developed. I'm going to skip this one. And that's where the whole concept of connected diagnostics came from. So I'll tell you a little bit about that, if you allow me, but I'll keep it not too detailed. Basically, the idea of connected diagnostics is that when a patient enters a facility, a healthcare facility, and the doctor thinks this might be typhoid or this might be malaria, then a rapid test should be available. And that rapid test then should be digitalizable. So in this case, you see a machine, but nowadays you can also use your mobile phone and just make a photograph of that rapid test. You upload that photograph into the cloud, and you use that information to channel, for example, money for the right treatment to the right patient at the right time. So if you test positive for malaria, you will get some money in your mobile phone with mobile money to pay for malaria treatment. But if you test negative, you don't get it. Yeah, so diagnostics can become a kind of a gatekeeper for targeting money streams for the right disease to the right patient at the right time. And you can use artificial intelligence in your apps, in your phone, to help also make decisions. Which means, I mean, a doctor knows what to prescribe and a nurse knows what to prescribe. But maybe the small drug shop around the corner who is selling drugs has no idea what to prescribe, and most likely half of the drugs are illegal. And so if you can look over the shoulders of less trained people by diagnostics that are digital, you can expand your manpower in healthcare. Because now you can look over their shoulder, you have a quality system, you make a photograph of the test, and you can go back to that photograph and see whether the decision was right or wrong. And so that is a way of bringing diagnostics closer to people. I'm just going to very briefly show you how this all developed in terms of rapid diagnostics. This is what happened. The first thing we did in Kenya was in 2017 about brucella. Brucella is a very, it's a bacterial disease. It's in milk, it's in blood of infected animals. And if you don't boil your milk, then you can drink it and you can get infected. Also, it can be, some people in that area drink blood or they make food with blood, and blood, of course, contains the bacteria. So there was a certain risk, but we said, well, let's test in Samburu this particular disease because it is a rare disease. It is a nomadic tribe in Samburu in Kenya. They have mobile phones. If it would work with them, then it will work with everybody. So here you see how they live and where they are. The huts, they live for a couple of months in one hut, then go to another one. So a very difficult population to follow. But the only thing they do have is their mobile phone, which is always in their pocket or in their hand. So that's what we did. We used fever guns to go through the villages and measure fever on people, which was considered hilarious because the people were used to a Kalashnikov and suddenly they get a new kind of gun. So it attracted a lot of attention and people came. And whenever somebody had fever, we went for a rapid test for Brucella. So then we tested in very small laboratories the Brucella cases. And yeah, we integrated this in a very first version of mobile payment for Brucella. So whoever tested positive got money for Brucella because then you can buy your antibiotics and you are safe again. Okay, so that's what we did. And here you can see positive and negative cases in a certain geographic area. Over time, you see an outbreak there of some positive cases in red. And eventually you see people getting cured. And eventually at the end, we had a kind of a flight radar for brucellosis. Also, we could identify individual patient cases and we could identify clusters. And for example, in the middle picture, you see a cluster of positive cases close to a Google Maps infrastructure, which later on appeared to be a slaughterhouse. And that's logical that you find Brucella there because there's a lot of blood around the slaughterhouse. And the women around the house were selling even blood soup to people who were drinking that. Yeah, so it shows you that you can use digital diagnostics to find hotspots of certain outbreaks in the middle of nowhere with remote people who are nomadic but who have a phone. And using this, we even could help the local vet because the local vet had some vaccines against brucellosis, but not enough for the entire area. But now we pinpoint, here is the hotspot, so you better vaccinate the animals around this hotspot. Same we did for malaria, a little bit later in Kisumu, and I think that is a similar story. I just had a nice discussion about malaria. Malaria is a big problem still. There's a whole list of facts at that time. Malaria is still very big, much bigger than brucellosis. So we thought, let's now move towards a real big disease. We have shown proof of principle with a simple bacterium in a nomadic tribe. Let's prove now the real big picture story, malaria. Let's do more with less. So we went to western Kenya, close to the Victoria Lake, Kisumu area. That's the Kisumu story. That's where COVID also broke out later on. And we started testing people using rapid tests in private facilities, uploading those tests. In other words, the whole story I just told you. And we see the numbers of cases over time in different healthcare providers. And we could monitor that. And we could monitor also the different rainy seasons. Yeah, and the outbreaks that were related to those rainy seasons. So you see the relation between weather and malaria cases. And we could find hotspots and say, well, this is the area where you really have malaria. And other areas of Kisumu, there's far less. So it helps also policymakers and health specialists in Kisumu to focus where are the bed nets going? Yeah, where are the repellents going? If you don't have enough, you have to target. And based on real-time information, you can then target the means that you have. And we also could look over the shoulder of the medical doctors. What kind of drugs are they prescribing for malaria? And these were private clinics. So you see that every provider here has a complete different choice of drugs. And none of them fulfilled the national guidelines. All of them were different. So you can imagine that the public health people were very interested in data like this because they said, this gives us a clue what is happening in the private sector and we can maybe correct a little bit left or right in their prescription behavior. Then we had second and first line prescriptions. Here is a provider that gave half of the patients a second line malaria prescription, which is ridiculous. It's far too much, it's very expensive. It will cost the healthcare system a lot of money. So at the moment you use digital diagnostics to look over the shoulder again of the prescriber, you can identify the leakages in the system and do something about it, either by training or by sometimes by, punishing is a big word, but sometimes you really have to have a serious talk with the clinic and say, listen guys, you can't just prescribe second line drugs all the time, just for financial purposes. Also, we could see the big difference, the big overprescription that's taking place. Many doctors overprescribe malaria drugs because they don't have a laboratory test, but they think, well, I better be on the safe side. Let me prescribe the drugs because maybe the patient has malaria and might otherwise die. So you see in the green line the total number of positive malaria tests over time in a clinic, and the yellow line the prescribed drugs. And you see particularly here in this beginning, the difference between those lines was big. In other words, a lot of overprescription. And when our intervention started, that overprescription went down big time. At the moment doctors know that you look over their shoulders, sometimes behaviors also are adapted. Also, we could target the poor. You can find out who are the poorer people in a certain area using digital means and target malaria funds to the right patients. And we could see which patient is going where, because now we know where they live, we know which clinic they visit, you know which clinics are the most popular, which ones are less popular and why. So it gives you all kinds of information that normally is not really that easily to get in real time. And you could get information also about the average distance that people walk to a clinic, because we know in which community unit they live. And so, for example, you can see on the second picture that people who are insured are usually walking or traveling 4 kilometers to a clinic, while the people who were not insured only traveled 2.5 kilometers. And so apparently insurance supports a bigger action radius for patients to seek healthcare in longer distance clinics. Maybe because they are a bit richer and they can pay their insurance fee, or maybe because the insurance covers them and they can use their money for paying for a taxi. But things are happening. I just wanted to say you can collect a lot of interesting information using digital applications that help you to interfere and to improve and to reduce inefficiencies. And one of the biggest inefficiencies, of course, is payment for healthcare. Malaria money now goes through the malaria funds to the governments of African countries. And then the money trickles down through a whole system, in this case Kenya, eventually down to the patient. But in every step, some money is lost, or gets into overheads, or is administrated in a creative way. But now, with this approach, using the mobile phone, you can directly pay the patient, or directly pay the clinic, by channeling money through malaria diagnostics to the right patient, for the right disease, at the right time. So we really do think that digital diagnostics can improve efficiencies big time in healthcare. This is opening hours, Monday, Tuesday, Wednesday, Thursday, Friday. You can see at which moment of the day people are doing diagnostic tests. What are their rush hours and what is their free time? So it can help you also to channel, to have a morning shift and an afternoon shift, for example, in your patients. To use those data for better patient management. So this is basically the dream, that if we talk about malaria, that was our topic, so I thought I'll take it also out. If you can somehow get the Global Fund, the big malaria payer, so far that they will say, all right, guys, I'm going to trust this system, and I'm going to channel my money through this digital health care to the right people at the right place, then we are really moving. instead of the model of global funds paying directly to governments. And of course, you can target also people. You can target the poor by using certain diagnostics and certain technologies. For example, by socioeconomic mapping. We're into that as well. So, the last 5 minutes of this presentation is a bit about this particular project. Why do we need so much more diagnostics in the coming years? Because isn't it NCDs that are coming up in Africa, and shouldn't we concentrate on heart attacks and on strokes? Yes, we should. It's a huge epidemic, for sure. But unfortunately, infectious diseases will remain there for a long time in Africa. They're still the biggest killer. And yeah, there are a couple of circumstances that will make it even potentially worse. And that's the very last part of my talk. Here we see a couple of those different diseases. And these are the rapid tests that we're developing, their prototypes and so on. You can see it looks a bit like a plastic little tube. And here's the mobile phone again that digitalizes those tests. So what is happening? Last part of my talk, 5 minutes in terms of infectious diseases. This is what we see happening in the world all over at the moment. Temperatures are going up. Between the year 1850 and 2021, these are the temperatures. Global warming. There's no doubt. I mean, this picture explains us basically everything. And if we look at the share that Africa had in the creation of this problem, well, Africa is in green. You can hardly see it. I think it's 0.3% or so of the contribution to global warming is from this continent. Yeah, it is mostly from Europe, United States, Australia, Canada, and so on. However, Africa is going to suffer again disproportionately from this whole warming. And we see it already now. The droughts that we see in East Africa are worse than over the last 40 years. There are all kinds of outbreaks. So the continent is really suffering and will suffer a lot from climate change. And this is a paper that just came out in Nature. Just to illustrate the picture, they did a crazy study looking at all the different infectious diseases that exist and how many are in fact aggravated by climate change. And their result was that almost 60% of all the known big infections can be aggravated by climate change. 218 out of the 375. In other words, when there's no rain and when there's drought, there's little water. If the water gets contaminated, many people will suffer. If there's a lot of rain, which also happens, disproportional, then you get floodings. And the clean and dirty water get mixed. Again, bacteria have a big chance. In other words, just an example, infectious diseases and digital diagnostics for infectious diseases will remain very important for the future as well. And that's where also healthcare technology, like digital health technology, for example, in a place like this, and research around it, and capacity building around it, can be so important. WHO information. Climate change is expected to cause approximately 250,000 additional deaths per year in the continent of Africa. Yeah? From malnutrition, malaria, diarrhea, and heat stress. This one came out, the boss of the Global Fund, Peter Sands, just last week. Probably the next pandemic is not COVID or not an unknown disease, it's a known disease. Something that we could prevent, but that just breaks out. And in fact, we might even see this happening because there are huge surges at the moment of cholera in Africa, all over the place in Africa. In more than 25 countries in Africa, new cholera outbreaks have been reported, based basically on water problems, lack of water and too much water. Infectious diseases will stay with us for a long time. They will need to be better diagnosed. We will benefit tremendously if this is done digitally. If we make Google Maps of it and if we put it on mobile phones and if we inform policymakers to make the right decisions for the right diseases at the right time. And that's basically the end of my talk. And thank you very much for your attention.
Let's put our hands together for him again. So we open the floor for questions. Questions?
Thank you. Okay.
Hello. Thank you very much for your talk. My name is Rinke. I'm from the University of Groningen, so also from the Netherlands. And I was actually wondering, as you were talking about digitalizing or like patients using patients using apps in order to collect data. How would, and given that there are so many young people also affected by infectious diseases, how could these patients also be included in, for example, oh, I'm so nervous, in these apps? For example, a 5-year-old, I would assume that they wouldn't have a phone, or also a 12-year-old, like how would these people be included? And how would data security of these patients then be ensured?
Now that's the question is of course about younger people and people who do not have a phone. Let's be clear about that. Still today, not everybody has a phone, and certainly not a smartphone in Africa. And many people share their phones. And a 5-year-old, of course, will not have a phone. Hopefully the mother has, but often also the mother doesn't have and the father has a phone. So yes, I agree. These are problems and challenges. So I also think that access to mobile phones is continuously increasing still in this continent, and it will increase for many years to come. I wouldn't be surprised, let's say in 5 or 10 years from now, that every 5-year-old also has a phone. You know, God knows where the limit is in this. I mean, this is so much part of our life now. So yes, I acknowledge we will never reach everybody, and we also might have confusions of people using each other's phones. But my question always is, the best should never be the enemy of the good. So what is the alternative? If we don't use the phones, then we certainly will reach far less people than if we do use the phones. So that you have to weigh that, I think. But good point.
My name is Prof. Sansan from the University of Life Sciences. There are 2 points. The first one, a point you made of results in South Africa not going to the correct patients. And I was a bit intrigued about that and wondering how this was able to happen, that the patients' tests are done and then the results go elsewhere. The second one was a point you made also about a system where the patient is tested, and then when it's positive, some money gets to the patient for the treatment. I was wondering, does the patient receive the money, or does the money go to where the treatment has to be taken and the patient just needs to report and take the treatment? Because I find that very, very interesting. And in your experience, are there patients who would receive this money or who would get this alert and would not go for the treatment? The last point is about digital tests for fever. You talked about malaria a lot, and you mentioned that there are other diseases that cause fever. a lot of this being produced, because that would then delineate malaria from all the other fever, the rapid diagnostic test to be used in this circumstance. Thank you.
Okay, well, I thank you, Professor. And it's I'm in the school banks again, who have to do my best to answer the questions. No, and it's good. What I'm referring to is that you can do diagnostics either decentralized or centralized. Now, in many places, decentralized diagnostics are hardly available. I'm talking about rapid tests that can be done in small clinics. In South Africa, for example, and I've lived there a couple of years, there is an intricate system of cars driving to the remotest clinics, collecting samples and bringing them to central laboratories where they are tested for a multiple number of diseases, because those central laboratories have the manpower and the machines, and then the results have to go back to the right patients. And they don't, that's where it really goes wrong. So I'm a big believer in point-of-care testing, because then the chance that you get confused is much lower. So that's the point I wanted to make in that respect. So in terms of fever testing, fever, of course, malaria is often the reason for fever, but there are many other reasons as well. And we are really looking for next generation rapid tests that can do differential, that can test for cholera, typhoid, malaria at the same time on a single drop of blood. That's exactly the project we're into now, to do multiplexing, as they call it, for different diseases that all have the same, that all create fever in one single test. And on top of that, we do it not on proteins, but on DNA. And on DNA, you can be much more sensitive. And if you eventually want to eradicate malaria, you will have to also be able to measure malaria in asymptomatic people who are completely healthy, but they still have the parasite. With a very sensitive test, you can find that. And that can help, of course, eventually to find out all the carriers of malaria, treat them, and get rid of a disease. And that's the future thinking, of course, around that. Yeah. Your second question now. Oh yeah, yeah. Okay. Let me be very clear about. I'm describing partly still a dream scenario, right? In other words, up to now we never were able to channel money to the individual patients, but we channeled it to the clinic. Yeah, so what we did is digitally follow patients, and by the end of the week, the clinic gets paid in a digital manner for the number of patient cases that were identified. Yeah, so that's at the current situation. That's our Chinese interface, as I would call it. But the dream, of course, is that you can empower people at home to test themselves for X, Y, and Z, with a cough app, as I said, with a rapid test for maybe 3 or 4 different febrile diseases. And they can see, okay, there's reason for me now to go to a clinic. Because those home tests, like the COVID tests, they are never perfect. These cheap tests for $1 will make mistakes. But they are a very good first line of triage to find out whether something is wrong with you or not. And based on that, you go to a serious clinic to get tested, yes or no. So that's kind of the philosophy, the thinking behind it. Yeah. There's another one, but maybe...
Thank you. My name is Husseini Alidu from the Department of Medical Laboratory Sciences. Digital diagnostics, so interesting and so informative. Wonderful presentation. As you were presenting, my concern was very simple. If you look at epidemics and programs that come with them, global funds, the world brings money when epidemic comes because everybody is concerned. But after the epidemic wanes, after some time, the interest and funding become a problem. Yes. And then local capacity becomes now what is important. Yeah. I'm looking at digital diagnostics, very interesting. But clearly from the way you are presenting, the rapid diagnostic test kits have to come from somewhere. And then we are still dependent. It's still a problem. If you look at COVID, COVID came in because we didn't have the capacity for vaccines. Africa will have been left to die, if not because of natural capacity of immunity. If we had to get the vaccines to survive, like the way Europe and Americas did, would have been largely gone. And so I'm thinking about, what is your view about local capacity to develop rapid diagnostic kits? Because eventually the money is there now. The world is focused in Africa to save. Eventually COVID will go. The interest will wane. The funds that are coming in will go. If local capacity is well built and somebody can sit in his laboratory there and produce RDTs, even when the fund wanes, some intervention will go great. So what's your opinion on that? Thank you.
It's not only your T-shirt that I like, but it's also your opinion here. I mean, yes, of course, the COVID epidemic has shown us once again the crying shame of discrepancies in this world. We in the Netherlands had enough vaccines to vaccinate our population 3 times. But those vaccines never were sent to Africa. We didn't even collect money. We got our vaccines for free. We go somewhere as a Dutch citizen, you get your vaccination, you sit there for 15 minutes, put a barcode on the wall and let people at least pay for the treatment or the vaccination of 1 African or 2 Africans or 5 Africans. A missed opportunity to raise money. Of course, these are all anecdotal solutions, not structural. So I totally agree with you. There should be capacity building in the African continent to produce its own biomedicals. Not only diagnostics, but also drugs and medical supplies and utensils. There are initiatives ongoing. Africa CDC in Addis Ababa is very strongly supporting this also. I just was in Senegal in Pasteur Institute, Institut Pasteur, where they really have made now the first production lines of rapid tests for malaria, for typhoid, for brucellosis, for leptospirosis in that particular institute, locally produced. Yes, we know now that when there's trouble, Africa is on its own. So you better help yourself. And I am a strong supporter of that. I also would very much support any entrepreneurial activity in this country to produce its own medical reagents, drugs, diagnostics. We have a whole network in this area. I will be happy to talk about that.
Hi, Tobias. Thank you very much for your presentation. My name is Ruben. So I was intrigued by your presentation. From what I got, you got some funding to carry out this project. To what level has policymakers in Kenya, for example, accepted it as something that should be routine in their mainstream administration of health?
Yeah.
That is the first thing. Because I sense that sometimes there's a bit of resistance from the politicians and policymakers in implementing some of these things. Yeah. So in connection to that, I mean, we've tried several times to actually get our own platforms for testing, especially when we started testing for COVID. We started creating our own master mixes and stuff. But the support, immediately a politician hears that you didn't use the reagent that was brought from China or was brought from somewhere else, then there's a lot of question about it. So to what extent, what is the resistance you faced, especially with the policymakers, and how addressing those?
Yeah, you should have been here's another candidate who should have been in Accra yesterday, right? I mean, because this is exactly, of course, the issue. How does research and science inform policy and so that actually things change? And what are the good things to do there, and what are the things that we forget all the time? One of the big lessons of yesterday was, whatever you do, involve the local policymakers and health implementers as soon as possible in your program. Make them part and parcel of what you're doing. Let them look over your shoulder. Invite them to your meetings, but don't let yourself be stopped by them, because you start usually in a small private environment. And so our trick is always start private, go private, to grow public. In the private sector, you can often do things very quickly. But if you just do it in isolation, it will not work very well. But if you involve the public sector from the very first moment onwards, let them co-create the tools that you make. Let them indicate which indicators are important for them. And also provide them with interim information during the rollout of a project and link them up to the ongoing private efforts. Then you get a different picture. And that's what we saw happening. The government itself came to us at a certain moment saying, we want your tool. We take it over. We bring in our own healthcare staff to roll it out. We bring in our own clinics to roll it out. Okay, funding-wise is still, that's the next level. That you get a local government really to pay cash for certain interventions. I have to say that I did not reach that level of wisdom yet. I hope to reach it before I retire, at least in one circumstance. Yeah. But in kind, governments can do a lot.
Okay, I have the mic.
You have the mic, I see it.
I want to sit down and ask my question, otherwise I'll be too tall for many people. Yes, it means you can also rest. Actually, in your presentation, I was just relating back to the era of COVID, the several self-medications that we saw people going through, including myself. When I start coughing, I look at the likely medication that I can take to subdue it. There's one concern I have, and I don't know whether in your, I'll call it exploratory work, whether in the process of making diagnosis access available to people through the digitalization, because especially in the area of mobile phones and things like that, whether maybe you didn't see any repercussions that could occur to people becoming self-doctors, giving themselves self-medications without really understanding the implications of it. Or in other words, the use of the established facilities where we have experts to make sense out of the diagnosis that the person is seeing just on phone. I mean, it's interesting. You take your phone and I won't say everything. I was talking to my senior brother and he's gotten some local herbal treatment he thinks could help him and all those things. And when I was asking of the safety profile and all those things, I think I set him thinking. You get the whole thing. But the speed with which he was getting, he had read online because he's on the mobile phone somewhere, I have a concern. How are you addressing that? How did that feature in the work that you did? Otherwise, very soon, people won't see any need to go and see a doctor when they are sick. Self-diagnosis through these digital processes, and I think that is going to lead us. My name, but I'm OA.
No, it's a clear question, and I mean, let's face it like this. In this room, or if I talk for myself, when something, or you often first go to your neighbors, your husband, your wife, and maybe you still have something in your cupboard, maybe some paracetamol, you know. That's usually how you start. And then when things don't disappear, then you start to think, well, maybe I should do something more than that. The whole area of traditional medicine and of self-medication is an existing phenomenon all over the world, and certainly also in this continent. I'm not an anthropologist, and I find it very hard to make any statement on how to manage this. I also do think that some traditional medicine certainly has good effects as well. It's not always that only the formal medicine is right, so it's a difficult area to discuss. But I do think that if you compare the situation, you should compare the situation with having not the possibility to test yourself at home. So if you test yourself at home for a disease X or for a cough, at least you know something. If you cannot test yourself at home, you know nothing. And indeed, it could be that people will overreact by self-prescribing certain drugs or herbs or things. I wouldn't dare to make a statement how big this problem will be. And I think it definitely needs attention. We did not look for that ourselves in our work. It's a good point. Humans are humans. They make a lot of irrational decisions, usually. Think about, the biggest decisions in your life. Do you make them rationally? Your wife, who do you marry? Your house. I mean, these are often decisions that you just make in different ways than straightforward rational thinking. So, yeah, I do recognize there is a risk of over self-prescription maybe of medicines if you can diagnose yourself at home for diseases X, Y, Z, P, and Q. To what extent? I don't know. Yeah. It's difficult for a scientist to say, I don't know, no. Scientists usually don't know things, and that's why they're scientists.
Before we take the next set of questions, we'd like to go online and check whether someone has a question online.
Okay, how many people do we have?
Okay, there's no hand up, so... Okay. Dr. Kaba.
Thank you, Tobias, for that wonderful presentation. As always, it's always a pleasure listening to you. My simple question is, why don't we still have a vaccine for HIV and AIDS?
Simple question. Why don't we still have a vaccine for HIV, and do we have vaccines for COVID within 9 months, right? Yeah. Just to make very clear to you, the money that was spent on making COVID vaccines in 9 months' time was equal, no, it was even double the amount of money that has been spent on HIV vaccines over the last 45 years. So my answer is, number one, put a lot of money in it. Throw a lot of money in it. That can accelerate your research. And we know where the priorities of the world are. They are not in malaria vaccines and not in HIV vaccines that we've seen. Again, another unacceptable situation, in a way. In terms of HIV itself, it is, of course, one of the most variable organisms that we know. It changes continuously. It mutates very fast. It is extremely difficult to make a vaccine against a that changes every second of the day into something else. So, biologically spoken, it is just very hard. But what I can say is that a lot of failures for vaccine development on HIV have contributed to the success of COVID vaccines. And so the whole RNA vaccine technology had been developed for HIV. It did not work for HIV, but it laid the groundwork for COVID vaccines pretty quickly. Godwin there.
So thank you very much. Fantastic work. I want to know what in to European in Africa the story is pretty different. Of course, about Kenya. Kenya, what happens in Africa? What is to actually rope things happen?
Yeah, so the question is not this story was deliberately also on Kenya because there's it gives a bit of a freedom to talk also and about digital, and also because Kenya is very advanced in terms of digital money, M-Pesa and stuff like that. So that's related to this. But of course, I mean, these types of interventions are doable in many places in Africa, of course. In Ghana, Maxwell can tell you a lot about different digital interventions we're doing in this country. Not so much in diagnostics, by the way, but in other areas. So, you know, I think there is no country limit to going digital, right? You can basically apply it everywhere. So I wouldn't see any objections, unless you get into a country where, let's say, mobile health data are completely stopped, or where the internet is blocked, or things like that, which sometimes happens. So I see a big future for it. Okay.
Can we kindly put our hands together for him as he takes his seat? Thank you very much, sir. We'll call on the registrar to come and perform a duty. Let's put our hands together for her as she comes up.
May I humbly invite Professor Tobias? Please come. I read a citation in honor of Professor Tobias F. Rinke DeWitt. UHAS appreciates you for your contribution towards research in the area of diagnosis of infectious diseases in Africa, health quality improvement, innovative healthcare financing, supported by mobile health technologies. We also acknowledge you for leading the development of the so-called connected diagnostic technology for improved quality and financing of healthcare delivery in Africa. UHAS recognizes your work on COVID-19 in Africa, in particular, digital mobile rapid diagnostics and the effect of African immune activation status on COVID-19 symptomatology. That's a big one. We honor you for your diligent service towards Africa and the global health fraternity. You say Aiko. Aiko is done. Ghana without us. No, then you haven't arrived in Ghana and the Volta region, the oxygen city of Ghana. So we will do this. Would you mind? give it to him.
Let's put our hands together for them as they take their seats. We'll kindly call upon the chairperson to give her closing remarks. Let's put our hands together for her as she comes up.
Thank you very much. All too soon. We are done. Oh, are we not done? We're going home very soon. But the lecture, I cannot summarize. If I do attempts, I would think I would dilute it. But I picked a few things that I wish to draw attention to. So the lecturer mentioned the concept of transparency and speed. Some of our guests that asked questions also alluded to how difficult it may be for some participants or users of digital service to be transparent. That means that as we navigate the space of digitalization, we need to have validation of data. If I'm saying I'm Lydia, am I really Lydia? What interface can we bring into the whole package to validate information within our space? Then speed. From 33 testing facilities to 111 facilities. I was just thinking that if we are going to replicate such a study in Ghana, is it by region? So he said county. So, all right, so county is the region. Then, okay, so which of them are we going to ballot and pick? For political reasons, my own village will be part of it. I wish to draw attention to fairness when we're selecting project sites. One participant alluded to funding and sustainability. The people who went around to take the temperature or who did the testing, who paid them after the project, where are they now? The training of such people. If they go, will they sleep there or they'll come back? How long are they going to stay in that community and all that? I wish to draw attention to the fact that we need to have realistic budget for projects, and also, like our speaker said, bring in the players, the stakeholders, so that after sustaining, upscaling, continuity will be easier within our space. One thing that made me very excited was the mobile money. In Ghana is the issue of e-levy. And so who sent the mobile money to who? Would they add the e-levy to the budgets? Before you send the money, did I say I cannot pay myself? Or I lied by saying I cannot pay? There are a whole lot of issues, and I kind of agree with Prof. OA that even as the world digitalizes and we all embrace it, we need to look at our context and whatever we're going to do moving forward, see how we can tighten up some of the loose ends, especially within our context where some people are not educated, as in school, some cannot read and write, language barrier, and all that. But I'm very, very happy that Kenya had a success story. I wish to ask that if there will be any other pandemic in the future, Ghana should be one of the beneficiary sites for the project because it will be interesting to compare countries and see how we are doing within our own continent. We have learned a lot, especially myself. I've learned a lot from your presentation. You said you are a teacher. You really taught us. You didn't present. You were teaching us, and I'm happy that you came. As you leave Ghana, we hope that, like we discussed earlier, we will continue to work together. And for those of us here who schooled elsewhere, somebody has brought the supervisor, you to bring yours. The moment the person wants to come, tell us, so we'll create opportunity for you and for the university to engage so we can work together. On that note, we wish to say that those who made time online and those who came physical, we are grateful to all of you. And for the Office of the International Programs, kudos for the good work. And to the organizing committee, the ICT, everybody else, we are grateful. Public Affairs, you marketed the program, the students who made it. We are very, very grateful that you were able to come. And like I said, our doors are open and we wish to engage anybody, all of us who want to work with UHAS. Thank you very much.
Thank you, Prof. Chair. Also soon we've come to the end of the program. We'll take some photographs, so kindly stay put. We'll ask Prof to come to the front and have a picture with senior management. After the deans and directors join. We'll take that and take everything. Director. Director. Deans and directors kindly join. Come to the next one. Come to the next one. Come to the next one. Can we all join, please? Please, let's all join up, please.